name is Matthew. Today I'm going to be discussing synchronized cardioversion. Synchronized cardioversion is a method used to put the heart back into a normal rhythm in patients with a rapid ventricular rate associated with severely cardiac compromised patients. This may include a decreased level of consciousness, hypertension, with a blood pressure below 90, chest pain, and heart failure. So indications for synchronized cardioversions are rapid ventricular rate accompanied by severely compromised cardiac output. These include pulsatile VT, supraventricular tachycardia, atrial fibrillation, and atrial flutter. The complications associated with synchronized cardioversion are VF pulsus VT and patients with dysrhythmias with adequate cardiac perfusion. So the equipment you'll require to do this procedure would be your LifePak 15, your multifunction adult defib pads. You want to have some advanced airway equipment and some oxygen therapy, so you want to have your BBM, some oxygen mask. You want to make sure you've got some suction equipment ready as well, and some sedation agents as well for the procedure. Now we're just going to go through the synchronized cardioversion procedure itself. So step one is you always want to explain the risk and benefits associated with the procedure to the patient as well. I know it may be time critical, but they're just so they're aware of what might possibly happen as well, so that their heart might revert and they can sort of go back into a normal rhythm, be well perfused, and also the adverse effects of performing the procedure. Now you want to establish IV access prior to doing the procedure and possibly have IV fluids running as well. Ensure you have medications drawn up and ready to go just in case anything happens. So you want to have some adrenaline drawn up, some amiodarone or some amiodarone, some adrenaline, so your resuscitation drugs. Also, you can start to prepare your sedative agents as well. So depending on what you're going to use for the procedure itself, you might use some ketamine and some midazolam. Then you want to have your patient hooked up to monitoring. So you want to have at least like the electrodes placed on the patient as well to monitor the ECG. Have pulse oximetry running. You want to check your equipment, so make sure suction's running. You have O2 therapy running and applied to the patient, especially if they get a bit of a decrease or hyperventilate during the procedural sedation part. Next thing to do is you've got everything set up, got your patient monitored, you've checked their blood pressure, you've got their respiratory rate, so you've got a good baseline set of observations. Now you're just going to apply the pads. So with the pads, you want to sort of under the right clavicle there, so you want to place one pad over there and then one below, just on the left side there as well. So it sort of follows the conduction motion of the heart. So once that's done, you want to power up your LifePak. Once it's all connected and hooked up. Now, when it powers on, you want to synchronize, and you want to make sure it's synchronized into the R waves of the ECG waveform. Now, with the energy select, you start off with the first shot. You want to go to 100 joules. So you just select your energy, which is the button on the right hand side here, and you can go up or down. So we just want to go down to 100 joules for the first synchronized cardioversion. So then we've got it synced to the R waves, making sure it's lining up. It syncs the R waves, making sure it's lined up. Then you're going to charge. At the moment it says it can't charge in sync mode. So what I might do is I'll just take it up and I'll just pretend it's charging up at the moment. So that's charged, it's synced to the R waves, and then you want to make sure everyone's clear. The patients have received their prequel analgesia and sedation. They've got oxygen therapy running, it's synchronized the R waves, and you want to deliver your first shock. Alright, once that's done, analyze the ECG rhythm, assess your patient again. If the patient hasn't cardioverted, they might require additional shocks. So this additional shocks should go up by 50 joules. So the next shot's going to be 150, and then the third shock's going to be at 200. So again, to energy up to 150, and then you want to synchronize it until the R waves is on form there, and then that's really basically sort of it. And then if they're reverted, then you just look at your extrication. Now, just to recap the positioning sort of thing, so it's going to be the right lateral and left anterior just below the nipple line. Alternatively, if you can get it anterior and posterior, so one on the front, one on the back, with the pads marked for the one for the right upper, one should be at the front and the back. This provides a direct cut and follows the path very directly through the heart. Now there's a few special considerations. So if your cardioversion didn't work the first time and you've got your pads anterior and laterally, consider reversing them to anterior posterior. Also, you want to check to make sure your device is syncing on the R wave and it is being detected. Now in pediatrics, it is rare that you will require cardioversion, but if you do, the recommended joules is 0.5 to 1 kilos for the first shock, and then increasing supplementary up to 2 joules per kilo. Now, it can be safely performed on pregnant women without disrupting the electrical activity of the fetus. And if it hasn't worked the first time, you want to consider other causes, so your hypovolemia, your electrolyte imbalances, your congenital heart defects, and also any stress and normal electrical conduction. Now, there are a few complications associated with this procedure, so normally pain or discomfort would be one of the ones. Any skin burn caused by the pads. You may get a paradoxical asystole or VF sort of rhythm change. You might get dislodging of blood clots, which may lead to strokes. Any pulmonary edema, bradycardia. Also, you might get transient hypertension. If you use procedural sedation as well, there's always the risk of aspiration or the patient obstructing their airway. There are a few safety considerations. So if the patient has a pacemaker previously inserted, you want to apply the pads at least 12 centimeters away from it, as the shock can disrupt the settings of the pacemaker and cause damage to the pacemaker itself or the wires. If sedating the patient, caution should be required about aspiration of the stomach contents. If it's appropriate, you may be able to insert a nasogastric tube. Be aware of any electrical hazards that might be for yourself or others, any water, any presence of metal, like flammable material, anything that they can really conduct through. You shouldn't have any direct contact with the patient when cardioverting, so it should be like when you're doing a sort of a defibrillation shock as well, make sure everyone's safe and clear. And then minimise the space between the pad and the skin, as this can create a spark. So what you want to do is, if the patient's a little bit hairy or wet sort of thing, you can shave their chest and just wipe their chest down with a towel or cloth. So I'd just like to briefly discuss the documentation required. So you just want to put down your rationale for the synchronized cardioversion. So the patient was cardiovascular compromised, they might have been hypertensive, poorly perfused, and at risk of arrest. You want to put their underlying rhythm down and associated signs and symptoms. So again, document blood pressure, heart rate, pulse oximetry. You want to make sure you document the success and failings of the synchronization or the cardioversion, and also complications that may have risen from the cardioversion as well. So if they've got any burns or abrasions or pain, or complain of pain after the procedure. Just document your settings and what time and what joules you've had the shocks delivered at, and then also the consent that you gained by the patient about and then mention the risk and benefits discussed with the patient prior to commencing the procedure. My name is Matthew, and I'd like to thank you very much for listening.